Bismillahirrahmanirrahim. The next part of the nephron is loop of Henle. So loop of Henle has different parts. First, the loop of Henle carries filtrate from the proximal tubule to the renal medulla and back to the renal cortex, because it makes a loop. So it comes down from the cortex to the medulla, and then it loops back upwards, goes upward towards the cortex again. So there are three basic functional divisions of the loop of Henle. If you remember from your knowledge of physiology, the first division is a thin descending limb. Thin descending limb is coming down. The thin ascending limb and thick ascending limb. So the first two portions are thin, either descending or ascending, and the last portion is thick, that is ascending, that's climbing up. So what is the basic difference between all these segments, the thin descending and the thick ascending? It has a functional difference. Because the thin descending limb of loop of Henle has leaky, tight junctions. So these junctions allow water to leave by passive diffusion. As the you can say tubule segment enters, the tubule segment enters a hypertonic renal medulla. So hypertonic means that it has a force. The tonicity plays an important role. It has a force. The water flows, water reabsorbs back into the blood by simple diffusion. Well, what other thing? In addition, urea and you can say the sodium diffuse from medullary interstitial fluid into the lumen of the tubule. So again, that is you can well relate that from your physiology knowledge. Then there is thin ascending. Now the thin descending is permeable to water, while thin ascending, now the loop is climbing up. The thin ascending limb of loop of Henle, how can you distinguish that? It is distinguished from the descending limb in that the tight junctions are now, you can say, are now really tight and impermeable to water. They have smaller gaps as compared to descending limb of loop of Henle. So as the name suggests that the transition from descending to ascending, the tubule segment makes a 180-degree turn and filtrate is now being carried back towards cortex. So from the cortex, as it comes from the cortex to the medulla, and when it takes a 180-degree turn, then it goes back towards the cortex. So then there is a thick ascending. After the thin ascending, there is the thick ascending, and the epithelium of the thick ascending limb of loop of Henle, it also contains tight junctions, the very tight junctions, and the most important transport protein in this segment. So there are many transport proteins, or the transporters you can say, are there, which the most important, it is here you can see on the screen. This segment we are talking about, this is a thick as compared to this thin. This is descending. It makes a 180-degree turn back into the cortex. Then while entering in the cortex, it has the epithelium which has a tight junctions, and this is thick as compared to this segment. So that is why it is called thick ascending limb of loop of Henle. This here, just before the distal convoluted tubule, at the last moment of the thick ascending, there is a transporter protein. There is this transporter. So transport could be different. I just tell you after this what type of transporters could be there in this epithelia. So at this segment, this is the most important one. What it does, it transports at the same time the sodium, potassium and 2-chloride ion. So this channel or this transport protein or this transporter, all for this one name, same name for the one protein. You can say it a channel, you can say it a transporter, or you can also call it as a transport protein. So here you can see all the arrows in one direction. It means what we have already discussed. If the arrows are from here to here, and then it is called reabsorption. If arrows are from here to here, then it is called tubular secretion. So this transporter protein simultaneously transports one sodium, one potassium and 2 chloride. As you can see the charges, this is positive, positive and negative. So one positive makes 2 positive, while 2 chloride are negative. So this channel is also called electrically neutral because it transports same amount of charges at the same direction. So towards the same direction, so that is why it is called symporter. Transporter, so symporter if all the ions are being transported towards one side, either from this side to this side or from this side to this side. All the transporters, all the ions are being transported at the same direction. So this transporter is called symporter, and the transport itself is called symport. While this transporter, this transports two ions on different directions. Sodium is being reabsorbed while potassium is being tubularly secreted in opposite directions. So that is why it is called an antiport, or this transporter protein is called antiporter. So this is an antiporter. What actually happens here? Potassium, we will start from here. The drugs included in this segment are bumetanide, ethacronic acid, furosemide and torsemide. The most important drug amongst all these is furosemide. This is most widely used, and this is of most clinical, whether it is for the treatment of many diseases, or the edema or heart disease, edema associated with the cardiac disease, or this is for imaging of the renogram. This drug is very important. So here we have already seen it. So this actually happens here. This is the name of the transporter. This is urine lumen, this is interstitium, and here is the blood vessel. What actually happens? Sodium, potassium and 2 chloride are being reabsorbed, comes into the cell. So this sodium which comes here is transported or antiported against the potassium. Then potassium comes here, and some of the potassium goes outside, while some of the potassium is being reabsorbed with chloride ion. Then here, so this potassium which goes into the urine makes, because this is a positively charged ion, the sum of the potassium which goes through this channel to the urine lumen into the urine. This makes the potential positive. How much? It is around, depending upon the quantity of the potassium that is being excreted out, this is usually between 6 to 25 millivolt. So this much charge, if you remember from your physics knowledge, that it is the positive or negative charge. Charges have an attraction, or simply the opposite charges have an attraction and the same charges repel each other. So once here in this filtrate is coming from where? It is coming from glomerulus through the PCT or the proximal convoluted tubule and into the loop of Henle. So magnesium is a positively charged ion while calcium is a positively charged ion. Here is no transporter which can transport magnesium and calcium. So what pathway they will take? Because potassium comes out and it simply repels magnesium and calcium, which take a paracellular pathway. But it doesn't get through the cells, rather it goes between the cell membranes of two cells. These are the tight junctions, but these have the pathway. This is the cell number 1, cell number 1, cell number 2, and cell number 3. So here are the gaps, not the very tight, like you can say impermeable. These are permeable gaps, although these are tight junctions, but these can allow magnesium and calcium to pass through this chamber and into the interstitium and back into the blood. So that is how this lumen positive charge repels magnesium and magnesium and calcium are reabsorbed through paracellular pathway in this segment. This is important because this will come in the later discussion. So what actually these drugs do? Now this was the normal physiology. Now what actually these drugs do? Simply these drugs block this transporter. So what is the mechanism of action of loop diuretics? Loop diuretics are the inhibitors of this electrically neutral channel which transports sodium, one potassium and 2 chloride. So what will happen? This is blocked here like this. So this sodium, potassium and 2 chloride ions will not be able to reabsorb, and this will also disturb potassium recycling. This is the potassium recycling here. So this potassium was again being carried through this. This goes to here, then this comes here, this goes back. So this is called potassium recycling. So once this recycling is disturbed, the lumen positive charge will also be disturbed, and this will cause excretion of magnesium and calcium into the urine. So calcium and magnesium reabsorption will also be disturbed. So loop diuretics, if we clearly talk about, approximately 25% of the filtered sodium load normally is reabsorbed in here. Then how this will affect different organs. Effect on urinary excretion. What happens when we give furosemide, which is a loop diuretic? It profoundly increases the urinary excretion of sodium and chloride, diminish the lumen positive potential that comes from potassium recycling. This effect cause an enhanced excretion of calcium and magnesium. We have already discussed these 3 points. Prolonged use. Now, if you use it for a longer time, may result in hypomagnesemia. Why? Simply because here magnesium was supposed to be reabsorbed, but due to use of loop diuretic, this potassium recycling. What is recycling? Potassium is coming from the blood into this cell, epithelial cell. Then there is a channel through which potassium goes out. It makes a potential positive here. Then it goes back here. From here, it is again reabsorbed here. Then from here, it again comes back. Then here, here, then here, here. So this is called potassium recycling, and this lumen positive charge is due to potassium recycling. Once you block this channel, what happens? This disturbs the lumen positive charge and blocks the magnesium reabsorption. Simply. So prolonged use of loop diuretics will diminish magnesium reabsorption, and ultimately they will excrete the magnesium into the urine. So prolonged use may cause hypomagnesemia. Why not hypocalcemia? Why not calcium? Because calcium reabsorption is also disturbed. Because there is a simple answer. PTH. What is PTH? Parathyroid hormone. Induced calcium reabsorption is increased after this segment. So loop diuretics generally do not cause hypocalcemia. And uric acid secretion is also enhanced in urine. What are the pharmacokinetics? If we talk about absorption, the oral absorption, they are generally rapidly absorbed. Absorption of oral torsemide is more rapid, as 1 hour than that of furosemide. The absorption of furosemide is around 2 to 3 hours. It's within like, so duration of action of torsemide is 4 to 6 hours and furosemide 2 to 3 hours. So as for the clinical indications, loop diuretics are primarily or predominantly used to treat edema. Edema of different causes. Edema. What is edema? Edema is the accumulation of extracellular fluid. So, for example, in cardiac failure, edema, low cardiac output results in poor renal perfusion. So this actually causes volume retention. If cardiac dysfunction is severe, means the heart is not working properly and the dysfunction is severe. So this volume retention results in edema and cardiac dilation. So cardiac dilation will weaken the heart, and it will have more water or more blood inside, so it will decrease the venous return. So what happens? The dilation, the edema and the cardiac dilation results or worsen the cardiac failure. Fluid retention in the lungs, because the blood is not coming back to the heart now as it should, so it will be retained within the lungs for the blood that has gone for the oxygenation. So this will cause fluid retention in the lungs. So this can produce the lethal or the grave consequences in heart failure. The loop diuretics reduce plasma volume, to cause migration of edema, a fluid from the tissue back into the circulation from where it can be excreted out. So what is the overall picture? This is the plasma here. This is, for example, I've already told it, interstitium or interstitial fluid, and here is the ICF. Intracellular fluid. My apologies for this sort of setting. So you have to bear with me again. This is the plasma, interstitium, and the cell. So what happens? This fluid volume increases. So once the furosemide actually decreases the plasma level, this fluid will move towards this side, and this will again be excreted out through kidneys once this plasma goes to the kidneys, into the urine. So this goes to the urine. This causes the depletion of plasma, so the fluid will move from here to here, and then from intracellular fluid to the interstitium, then from interstitium to the plasma, then from the plasma it will be excreted out of the body. So this is how loop diuretics can cause an effective management for the cardiac related edema. And this is also used for hyperkalemia. Hyperkalemia is the increased quantity of potassium in the body or the blood. By wasting the potassium, recycling, these can increase potassium wasting, and potassium can be excreted out into the urine. So these drugs can be used in hyperkalemia. Acute renal failure. So many primary and secondary kidney diseases. Primary diseases are those which do not have a definitive cause. So these diseases, either the secondary, for example, due to any secondary to any other reason. These are characterized by salt and water retention. So in kidney failure or kidney diseases, salt means sodium chloride, water retention occurs. Usually hyperkalemia is there. In these patients, thiazide diuretics can also be used. But why loop diuretics are preferred over thiazide? Because thiazide diuretics become ineffective when the glomerular filtration is less than 30 ml per minute. Remember this. So loop diuretics are the primary drug of choice for volume management in renal failure. And edema that originate from primary liver disease. In these settings, the edema results from the low plasma oncotic pressure. It means that plasma proteins are not being formed by the liver because of the primary disease of the liver, so which causes reduction in oncotic pressure, and from hypoalbuminemia, ascites. Ascites is a accumulation of fluid in peritoneal cavity. Low renal perfusion means due to less oncotic pressure, blood will move less towards kidney. So increased aldosterone release, so that is why low kidney perfusion will cause aldosterone to release in a great quantity. Loop diuretics have a special place in the management of this complex syndrome by reducing fluid and electrolyte retention by the kidney. So some patients as far as the edema associated with liver disease, some patients might be refractory, or you can say resistant to the loop diuretics, or other may develop severe hypovolemia. So a great care must be taken to have loop diuretics used in edema associated with liver disease. So other indications include aniline overdose, for example bromine or the bromide, fluoride and iodide. These loop diuretics can be used in the treatment of toxic ingestions. Why? Because here again, going back to this, loop diuretics basically bind to this segment where from the chloride ion is being reabsorbed. So thereby this segment is for anion transport, including the chloride. So thereby loop diuretics can also block the other. If you're going back to the periodic table, chlorine is placed in group 7 along with fluorine, bromine. So thereby these have the same capacity to be reabsorbed here. So loop diuretics binding to this site, they can block the entry of other anion ions, for example bromide, fluoride and iodide, in thick ascending limb of loop of Henle. But if you are giving for toxic ingestion of bromide, fluoride or iodide, you must administer sodium and chloride or the saline solution to replace urinary losses of sodium and chloride. These are the doses. For example, furosemide is total daily oral dosage is 20 to 80 milligrams. It's between that. Bumetanide is the most potent of all these, so that is why lowest possible dose is used. It's 0.5 to 2 milligram, because its efficacy, relative potency, you can see is 40. Toxicities include autotoxicity. This can cause the hair cell to damage, and hyperuricemia, hypomagnesemia and some allergic reactions, because furosemide, if you see, is a sulfur drug. Here again, bumetanide is a sulfur drug. So this torsemide is also a sulfur drug. This contains sulfur here and here as well. So these can cause allergic reactions. The sulfur drugs, if a patient is already there are some evidences that if the patient is already allergic to sulfur drugs, can have allergic reaction to these diuretics as well. Okay, then the next segment is distal convoluted tubule. What is the normal physiology of distal convoluted tubule? Here it's about 10% of filtered sodium chloride is reabsorbed in the DCT. If you remember, in PCT it's around 65%, in loop of Henle it's around 25%, and the 10% of filtered load of sodium chloride is reabsorbed in. Potassium is not recycled across the membrane of the DCT as it does in TAL, thick ascending limb of loop of Henle. Then there is no lumen positive charge in this segment, which occurs due to potassium recycling. So calcium is actively reabsorbed by the DCT via apical calcium channel and sodium calcium exchanger. We will see here sodium and calcium exchanger. This is calcium. It is actively reuptaken or reabsorbed under the influence of activin with the passage of energy, with the expenditure of energy. So what factor is there? This is the parathyroid hormone. This is the parathyroid hormone receptor, which influences this channel to reabsorb calcium. So here is the sodium and chloride. Sodium and chloride symporter. This channel, so sodium comes here, and then this is antiported. There is a sodium potassium ATPase. This is an active transport. Potassium from the blood comes out while sodium is again. So this is okay. Here thiazide diuretics. Now that was the normal physiology. Then the thiazide diuretics include hydrochlorothiazide is the most important one. Pharmacodynamics, so the mode of action or the mechanism of action, how thiazide diuretics act or induce their action. Thiazide diuretics inhibit sodium chloride transport in the DCT. Here, this transport is inhibited, or this channel. The proximal tubule may be a secondary site of action. Here, these can also act here. So by inhibiting sodium chloride symport into DCT, thiazide diuretics attenuate the ability of the kidney to excrete a diluted urine. Here, this chloride then goes, there is a channel here. This is calcium, we have already seen, back into the blood. Drugs, hydrochlorothiazide is the most important, then chlorothiazide, chlorothalidone, metazolone, then indapamide. So what is the overall effect or the organ system effect? So urinary excretion, so the inhibitor of sodium chloride symporter increases sodium and chloride excretion. That is the number one effect. Obviously, because sodium and chloride symporter is blocked, so sodium and chloride will be excreted out. So as we have just seen, that the secondary side of action might be the proximal tubule. So some thiazide diuretics also are weak inhibitors of carbonic anhydrase. So this effect can increase bicarbonate and phosphate excretion and probably accounts for their weak proximal tubular effect. So acutely, thiazide diuretics increase excretion of uric acid, but uric acid excretion is reduced following chronic administration. Chronic administration means it is if it is administered for many years or for prolonged time. Thiazide diuretics, if you see the clinical indications, are used to treat edema associated with heart, congestive heart failure, liver cirrhosis like renal nephrotic syndrome, chronic renal failure, and acute glomerulonephritis disease. We have already seen that certain renal diseases, many patients or some of the patients are put on thiazide diuretics, but if the renal clearance is less than 30 ml per minute, then the thiazide diuretics become ineffective. the most important, that was the edema associated with CHF, cirrhosis, or renal, same as tube diuretics. But this is the hypertension. This is the most important and most widely practiced indication for thiazide diuretics. Thiazide diuretic decrease blood pressure in hypertensive patients and are used widely for the treatment of hypertension, either alone or in combination with other antihypertensive drugs. In Pakistan, thiazide diuretics are not available as a monotherapy or for the sole treatment of hypertension. They are mostly available in combination with other drugs like ACE inhibitors, enalapril, and thiazide diuretic, CONVULATED. What are the benefits of thiazide diuretics in hypertension? Thiazide diuretics are inexpensive. They are very cheap, as efficacious as other classes of antihypertensive agents, and well tolerated. And their dose flexibility is their major strength. They can be administered once daily, do not require dose titration, and have few contraindications. Moreover, they have additive or synergistic effects when combined with antihypertensive agents. So other uses as nephrolithiasis due to idiopathic hypercalciuria, nephrogenic diabetes insipidus, and osteoporosis. So why these are used in these indications, and this has to do with this calcium reabsorption. If we talk about toxicities, or nephrolithiasis due to idiopathic hypercalciuria, because thiazide diuretics promote calcium reabsorption, or they preserve calcium within the blood. So that is why they are used for this. Toxicities include hypokalemic metabolic alkalosis, impaired carbohydrate metabolism. They can cause hyperglycemia, and they should be used with caution and the diuretics. Hyperlipidemia, they can cause 5 to 15% increase in serum cholesterol and LDLs. So this must be taken into account in the patients who have already increased serum cholesterol and LDL level. Hyponatremia is quite obvious, and these also contain sulfonamide moiety. These can cause allergic reactions, photosensitivity, and generalized dermatitis. Then we have collecting tubules. Collecting tubules are responsible. Now we are decreasing the sodium chloride reabsorption, because most of the sodium chloride has already been reabsorbed. This is normal physiology. This is why important this segment, despite of the fact that it is only responsible for 2 to 5% of NaCl reabsorption. Though it is small concentration, but still it plays an important role in renal physiology and in diuretic action. Being the last segment, it determines the sodium concentration of the urine. So lastly, most important site of potassium secretion by the kidney, and the site where all the potassium occurs. So collecting tubules are the mechanism of sodium reabsorption. It has a different way. There are two cells, principal cells, major sites for sodium, potassium, and water transport. Then the epithelial cells are divided into principal cells and intercalated. The second type of cells are further divided into alpha and beta segments. Alpha cells are primary sites for hydrogen secretion. Beta cells are principally involved in bicarbonate secretion. Here you can see here the alpha and beta. These are the intercalated cells. The principal cells are important for sodium reabsorption. Yeah. And this is again the water reabsorption by the induction of aquaporins or water channels under the influence of ADH, because this is the final segment where the final concentration of urine will be determined. So that is why it is more important. So what type of drugs? Okay, one thing I have missed is here the aldosterone. If you see, it is clearly mentioned that within the principal cell, aldosterone is released. Aldosterone receptors, they act. So aldosterone is a hormone. Aldosterone induces protein synthesis and induces sodium channel within the apical side of the membrane. So thereby sodium reabsorption is enhanced. Then this also enhances the sodium reabsorption through the basolateral membrane by the sodium potassium ATPase antiporter. So this all happens under the influence of aldosterone. As already mentioned, here most important site for potassium secretion by the kidney and the site where all the potassium exchange occurs. Here you can see there is no potassium that is coming back. There is no potassium. So once the potassium leaves this segment, it goes into the urine simply. So this is the most important segment for the potassium, and that is occurring under the influence of aldosterone. Why am I influencing this or emphasizing this aldosterone? Because we have a whole class of drugs which block this aldosterone. So thereby no sodium channel will be inducted and no sodium reabsorption will occur, and no potassium will be excreted out. Simply potassium will remain here. If you block this aldosterone, so aldosterone will not be able to bind with the receptor and will not be able to. So what happens, you will see afterwards. So here are two types of drugs under one class, and the overall class name is potassium sparing diuretics. Sparing means to leave. So potassium sparing diuretics, they leave the potassium inside the body. They do not. So if they are administered, they are given to a patient, they leave the potassium inside the body while they excrete out the sodium only. So there are two types of classes under potassium sparing. One is mineralocorticoid receptor antagonist or aldosterone receptor antagonist. In this class of drugs, we have spironolactone or spironolactone or aflatoxin. Then we have the second type of diuretics. These are inhibitors of sodium influx. It includes amiloride or amiloride, and then we have triamterene. So first we see the mechanism of action of mineralocorticoid receptor antagonist. So I just gave you a brief concept. What actually happens here? This is aldosterone. Aldosterone comes inside the cell. It binds here are the mineralocorticoid receptor, MR. Mineralocorticoid receptor. So in the previous discussion on receptors, we know that receptor drug binding is necessary for the action. So the aldosterone hormone binds with the receptor, and this receptor and hormone complex, because it is a hormone, so it induces protein synthesis within the nucleus of this cell. This causes the induction of aldosterone induced proteins, AIP. Aldosterone induced protein are what? They cause the induction of different channels. The sodium channels will be induced within the cell membrane. Without this aldosterone, these sodium channels will not be induced. They won't be present here. And they will also induce ATPase, sodium potassium ATPase. So what happens when we give our drug, that is potassium sparing? In potassium sparing diuretic, which sort of drug we give? We give spironolactone or eplerenone. Eplerenone and spironolactone block this receptor. Simply, they will block this receptor, so aldosterone will come inside and there won't be a receptor available for binding. So simply aldosterone will not be able to induce its messenger RNA effect, and aldosterone induced proteins will not be formed. So simply what happens, so what mineralocorticoids, these are the normal physiology. So consequently, transepithelial sodium chloride transport is enhanced and the lumen negative. This is again the normal physiology. So what happens? This will cause sodium and chloride ion reabsorption. This will hinder the reabsorption. So the second type of drugs, myloride and triamterene, these do not block aldosterone. Rather, they directly interfere with the epithelial sodium channels in the apical membrane of the collecting tubules that are not under the influence of mineralocorticoid. Since potassium secretion is coupled with sodium entry in this segment, these agents also act as potassium sparing. So these are also called sodium channel inhibitors. Here this is the overall picture. This is the principal cell. Here in this, there is the potassium channel. There is sodium that is normally present, this channel. Then the sodium will be reabsorbed. This will be back into the blood through antiporters. So these will block this channel here, and ultimately they will hinder the potassium exchange as well. These will act as a potassium sparing diuretics. These are the chemical structures. So spironolactone is a synthetic steroid that contains a lactone ring in its structure and acts as a competitive antagonist to aldosterone. So in a nutshell, the aldosterone and spironolactone have a very similar structure, and its action depends on endogenous levels of aldosterone that also determines its onset and duration of action. As soon as the greater quantity of aldosterone is present, they will have more effect, and their onset of action will be initiated. So therapeutic uses are quite obvious. Hyperaldosteronism. Primary hyperaldosteronism is a disease in which there is no cause, like Cone syndrome, ectopic adrenocorticotropic hormone production is there, and ultimately aldosterone level will increase. While secondary hyperaldosteronism is evoked by heart failure, cirrhosis because of fluid overload syndrome, any condition that involves depletion of intravascular volume. So the later effect may also be contracted by thiazide or loop diuretics, so they are used in combination. It means that if you give loop diuretic or thiazide diuretic, which can cause hypovolemia, so this can also cause increased level of aldosterone. So thiazide diuretic or loop diuretics, if given, they might be combined with potassium sparing diuretics. The second indication is myocardial infarction. So eplerenone is found to reduce myocardial perfusion defects after infarction. Hypertension, co-administration of sodium channel inhibitor augments the diuretic and antihypertensive response to thiazide and loop. We have already discussed that these can be used with thiazide and loop diuretics. And there is Liddell's syndrome. Amiloride is used for this syndrome. What is that Liddell syndrome? Liddell syndrome is a genetic disorder in which the sodium channel overworks and greater quantity of sodium is reabsorbed back into the blood. So it can cause hypernatremia or increased quantity of sodium in the blood, which could be lethal. Patient may not survive or may die in early age. So in Liddell syndrome, amiloride may also be used because it is a sodium channel blocker. Toxicities, since these are potassium sparing, means that they cause the potassium to remain within the blood. So, and they can affect the final concentration. So these can cause hyperkalemia, and this can range from mild to moderate or even life-threatening hyperkalemia. Hyperkalemia may be life-threatening. Why? This can arrest the cardiac movement. So this can trigger the repolarization. So this can be prevented by fixed dosage combination with loop or thiazide diuretics. So why these can be combined with loop or thiazide diuretics? Because loop diuretics excrete out potassium, while potassium sparing diuretics block the potassium. So this effect will be counteracted. Hyperchloremic metabolic alkalosis due to inhibition of hydrogen ion parallel to potassium ions. Endocrine abnormalities, since the potassium sparing diuretics have one class of potassium sparing diuretics is aldosterone or mineralocorticoid, so these can cause other effects like gynecological effects or endocrine abnormalities like gynecomastia. Gynecomastia is the development of male breast, impotence, and benign prostatic hyperplasia. These effects occur with spironolactone. Acute renal failure, if like triamterene, this is in the medical literature, is combined with indomethacin, this can cause acute renal failure or kidneys may not function. So kidney stones can occur because triamterene is slightly soluble and may precipitate in the urine, causing kidney stones. So drug is soluble in water. Then the last class of drugs we have AQUARETICS. This is important because this has mannitol, urea, isosorbide, and glycerin. These are high molecular weight drugs and what actually they do, these are also called aquaretics, that are important drugs because they do not cause sodium, or their mechanism of action does not belong to ionic exchange. Rather, they are simply water. They promote water excretion. They alter water excretion in proximal tubule and descending limb of loop of HENLE, because these two regions of nephron are freely permeable to water, as we have already seen that the maximum water is reabsorbed in proximal convoluted tubule and the descending limb of loop of HENLE, in which water is reabsorbed by diffusion. Okay, before moving ahead, first we need to describe what is meant by osmotically active agent, or what is osmosis. Simply, osmosis is the movement of water from the region of higher water concentration to the region of lower water concentration. Or the second definition of osmosis is from the region of lower solute concentration. For example, here is a solution A and solution B. If we add sugar molecule in these solutions, okay, fine, here is your entertainment. You can have a dhamal while listening to the lecture. Okay, here it is the solution A and solution B. So what actually happens, why, if these solutions have the same quantity of water? For example, this solution A has 100 ml water and the solution B also has 100 ml of water. But here you can see the quantity of the solute is different. So in this condition, if this is a semi-permeable membrane and these walls are permeable to water, oh, that was bad. I had again. So for example, these are the water channels, means the membrane of the container or the wall of the container is permeable to water only, not the solute. Here. Okay. And this is the semi-permeable membrane. Where would the water move? This region is concentrated. This region is diluted. The quantity of the water is same, but the quantity of the solutes will define from which container, A, either A or B, water will move from to which container. So water will move always from the diluted to the concentrated solution. Remember that. In terms of solute, if we define osmosis, water will always move from dilute to concentrated solution. So in this case, water will move from here to this segment or this container, from A to B. Why? Although the quantity of the water is same, but the presence of greater number of solutes make this diluted and makes this concentrated. For example, this has 25 grams of sugar while this has 50 grams of sugar or 75 grams of sugar. So this makes it diluted and this makes it concentrated, and water will always osmotically, so we can say the sugar molecule or any substance that is present here which can attract a diluted solution back towards itself, an osmotically active substance. So osmotically active substance can draw water towards itself. So this concept is the basis for the aquaretics. So these drugs alter the water excretion in proximal tubule and descending limb of loop of Henle. That's already discussed. Any osmotically active agent that is filtered by the glomerulus but not reabsorbed causes water to be retained in these segments and promotes a water diuresis. So what is the mode of action here? We have already described this segment, this section. So these are the osmotic diuresis, how these act. The site of action is descending limb of loop of Henle and PCT. These drugs exert their action by preventing the normal reabsorption of water by interposing a countervailing osmotic force. How? So what happens? These drugs are present in this segment. So these are higher molecular weight drugs. These are such higher that they can be filtered out through glomerulus, and these cannot cross this membrane. Simply, these can be filtered through the glomerulus and these cannot be reabsorbed into the blood by these cells. So these drugs stay here in the urine lumen. Okay, and since these are osmotically active, so these attract water towards them. So the water which is already present here will remain here in the urine lumen. So as you remember from our earlier discussion, anything that is present in this side or the urine lumen will go into the urine, and once this is depleted, these will attract water from intracellular fluid or from the plasma as well. So what does it mean? These their action by preventing the normal absorption of water by interposing. So simply these block the normal reabsorption of water by interposing a countervailing osmotic force, like opposite to that reabsorption. Interposing mean by implying. So thereby these increase the urine volume. An increase in urine flow also decreases the contact time between fluid and the tubular epithelium, thus reducing sodium and water reabsorption as well. What is meant by this? So if the water flows rapidly through this segment, this will also flush out the sodium as well. So effects on urinary excretion. Osmotic diuretics increase the urinary excretion of nearly all electrolytes including sodium, potassium, calcium, magnesium, chloride, bicarbonate and phosphate, because it is flushing. Simply, if you remember the river example, if the river is flowing at a greater speed, if you have seen a river, this will not allow, and you drop something into that stream of the river, it will simply take away that rapidly. You cannot catch it back. But if the river is stagnant, is slowly flowing, if you drop something, so you may be able to catch that. So simply, once you give the aquaretics, the water flows at a greater speed, or the diuresis occurs, which takes sodium, potassium, calcium, magnesium, chloride, bicarbonate and phosphate with itself. So again, pharmacokinetics, all are poorly absorbed, specifically mannitol. So it is administered orally. It causes osmotic diarrhea rather than diuresis. So clinical indication: increase of urine volume. Osmotic diuretics are used to increase water excretion in preference to sodium excretion. A reduction of intracranial pressure and intraocular pressure. So these drugs are given in intracranial. If the intracranial pressure is increased in head injury or in glaucoma, or before the ophthalmic surgery, because these can reduce intraocular pressure due to reduced intracellular pressure. Dialysis disequilibrium syndrome. Mannitol and urea are used in the treatment of dialysis disequilibrium syndrome. Too rapid removal of solute from the extracellular fluid by hemo or peritoneal dialysis reduces the osmolarity of the extracellular fluid. So consequently, water moves from extracellular compartment into the intracellular compartments. So this shift of fluid causes hypotension, because water simply what happens, why it is more good, simply what happens if someone is undergoing dialysis. So dialysis removes solutes. So what happens, cells have organelles which act as a solute, so they will be osmotically active. Now the solutes from the blood have been removed, cells have solutes, so water will move from plasma or interstitium, from the interstitium into the cells, because these are osmotically active. So this is called dialysis disequilibrium syndrome. So these diuretics cause correction of that as well. They simply take the water from inside. So that was the intracellular, that is plasma, here is the interstitium. So greater solutes here within the cell. These are the organelles. Once the dialysis from the vessel occurs, this removes many substances, so leaving the water in a greater quantity here, so water will move inside the cell. So this will cause dialysis disequilibrium. So what will happen when we give aquaretics? They simply draw the water from intracellular space back into the plasma. So that is why they are used in the treatment of this disease. Toxicities. Extracellular volume expansion. Obviously, these drugs expand extracellular volume prior to diuresis. This leads to hyponatremia. Why? Because the sodium will be diluted. Again, referring back to the same example, the normal quantity of the sodium in extracellular fluid is 135 or 145 milliequivalent per liter. So if you increase the liters, for example, someone is having 5 liter, for example, so 135 milliequivalent per liter multiplied by 5, so this will be the total sodium. If that person is having the same sodium level but greater volume, or volume has been expanded to 5.5 liter or 6 liters while the sodium remains same, so this will cause dilution of the sodium. So this will become hyponatremia. So these can, prior to diuresis, these draw water from intracellular compartment that comes into extracellular compartment, and diuresis hasn't occurred yet. So this may cause hyponatremia. So this effect can complicate heart failure or may cause pulmonary edema. Headache, nausea and vomiting are frequent. Once the diuresis start to occur, these can cause dehydration or depletion of intracellular volume. So this also, while the water is leaving, so this can cause hyperkalemia. Hyponatremia in patients with severe renal impairment, parenteral administration or parenterally administered mannitol cannot be excreted and is retained IV. This draws water from cells and leading to hyponatremia. This is a beautiful chart describing all the diuretics and effects on cations, anions, uric acid and renal hemodynamics. Thank you very much for your attention. Hope you have enjoyed your lecture. In case of any questions, you can ask me on WhatsApp group at any time.